Hello everyone. So I am starting a new initiative on my channel, and in this I will keep posting videos which will comprise of the one-liners of medicine, mainly from Harrison. And these one-liners or these notes would be helpful for NEET TSS aspirants, NEET PG aspirants, and final MBBS or even MD medicine students. So for more such videos, you can subscribe to our channel with this handle. So we will go on topic wise, system wise, and then topic wise. So first we will start neurology. This is first session in neurology, and the chapter is approach to the patient with neurologic disease. Each and every word of this video will be from Harrison textbook latest edition only. So let's begin without wasting any time. Neurologic disorders affect more than 1 billion people worldwide. It constitutes 12% of the global burden of disease and causes 14% of global deaths. So sometimes in MCQs they ask very weird database questions. So neurologic disorders around 1 billion people, 12% of the global burden of disease and causes 14% of the global deaths. Now some percentage for the neurological causes or neurological diseases. The daily neurological diseases is around 13.7% and death ratio is around 16.1%. Focal back pain, spinal cord sensory level and incontinence suggest a spinal cord origin. So if a patient presents with focal back pain, a spinal cord level and incontinence, that we should suspect spinal cord origin. A stacking glove pattern, that is glove and stacking pattern of sensory loss, it suggests peripheral nerve disease, that is peripheral neuropathy. Stacking glove neuropathy is or stacking glove and stacking sensory loss suggests peripheral neuropathy. Areflexia usually indicates peripheral neuropathy but may also be present with so-called spinal shock and acute spinal cord disorders. Now primary neuronal, that is gray matter disorders, often presents as early cognitive disturbances, movement disorders or seizures. So gray matter diseases, how they present? They present usually as early cognitive loss, early cognitive disturbances, movement disorders or seizures, while white matter involvement produces long tract disorders. MCQs can be formed. White matter involvement produces long tract disorders of motor, sensory, visual and cerebellar pathways. So this is the difference between gray matter disorder and white matter disorder. Now progressive and symmetric symptoms often have a metabolic or degenerative origin. In such cases, lesions are usually not sharply circumscribed. Few signs: Lhermitte sign, electric shock-like sensations evoked by neck flexion. It is due to ectopic muscle impulse generation in the white matter pathways and occurs with demyelination in the cervical spinal cord. So, important points about Lhermitte sign: it's electric shock-like sensation. It is evoked by neck flexion, and it is due to ectopic impulse generation in white matter pathways, and it occurs with demyelination in the cervical spinal cord, that is disease which causes demyelination of cord. Another terminology: fortification spectra. What is fortification spectra? Slow advancing visual scotoma with luminous edges indicates spreading cortical depression and typically seen in migraine patients. So important point for fortification spectra is it is slowly advancing visual scotoma and it indicates spreading cortical depression and it is seen in patients with migraine. Aminoglycoside antibiotics. These may exacerbate symptoms of weakness in patients with disorder of neuromuscular transmission such as myasthenia gravis and may cause dizziness secondary to ototoxicity. So aminoglycosides are not given in patients with myasthenia gravis and it may cause dizziness secondary to ototoxicity also. Vincristine and other antineoplastic drugs can cause peripheral neuropathy. So peripheral neuropathy commonly seen with antineoplastics, mainly vincristine. Immunosuppressive agents such as cyclosporin can produce encephalopathy. Excess vitamin A ingestion can lead to intracranial hypertension, that is pseudotumor cerebri or pyridoxine. Excess also can lead to peripheral neuropathy. Now few test of walking, a 7.5 meter or 25 feet distance. These few points are from general examination. So in test of walking, if we make a patient walk for 7.5 meter or 25 feet distance, normally patient should take 5 to 6 seconds. We should also note that if any assistance is taken or not, and repetitive finger or toe tapping is done. So normal repetitive finger or toe tapping is 20 to 25 taps in 5 seconds. So rarely these values can be asked in any MCQ exam. Now coming to the mini mental state examination. is a standardized screening examination of cognitive function. So MMSE is for cognitive function, that is extremely easy to administer and it takes less than 10 minutes. Now important to remember what is sensitivity and specificity for MMSE. It's 85% for making diagnosis of dementia, that is moderate or severe. Individual elements of MMSE can be subdivided into, so what are the individual elements of MMSE? Level of consciousness, orientation, speech and language, memory, fund of formation, insight and judgment, abstract thought and calculations. So these are the various elements for MMSE. Now muscle grading, that is power. So grading of power is muscle strength is traditionally graded using the following scale: 0 if no movement, 1 flicker or trace of contraction but no associated movement at a joint, 2 movement with gravity eliminated, 3 movement is against gravity but not against resistance, 4 minus, 4 is divided into 4 minus, 4 and 4 plus, so 4 minus is movement against a mild degree of resistance, 4 is against the moderate resistance and 4 plus is movement against strong resistance, and 5 means full power. So this is how muscle power is graded. Now muscle stretch reflexes, remember root values of important ones: biceps C5 C6, brachioradialis C5 C6, triceps C6 C7, finger flexors C8 T1, patellar quadriceps L3 L4 and Achilles S1 S2. Now grading of reflexes, as muscle power is graded, reflexes are also graded. 0 means absent reflex, 1 means present but diminished, 2 means normal reflexes, 3rd exaggerated, and 4th if clonus is present. Now with disease of the frontal lobe pathway, in any frontal lobe pathology, several primitive reflexes which were not normally present in adult but they may reappear. The 5 primary sensory modalities, which are the 5 primary sensory modalities: light touch, pain, temperature, vibration and joint position. So MCQ can be asked which of the following is not a primary sensory modality. So these 5 are the primary sensory modalities. Vibration is tested using tuning fork with 128 Hz. Now for joint position testing, the examiner grabs the digit or limb laterally and distal to the joint being assessed. Small 1 to 2 mm exertion can usually be sensed. So this can be asked that how much exertion can be sensed. So it's around 1 to 2 millimeter. Now the Romberg's maneuver or the Romberg sign is primarily a test of proprioception. Romberg test is done for testing proprioception. The cortical sensation is mediated by parietal lobes. Cortical sensation by parietal lobes and represents an integration of the primary sensory modalities. The testing cortical sensation is only meaningful when primary sensation is intact. So MCQ point, cortical sensation is by parietal lobes. So with a parietal lobe lesion, the patient may be unable to identify the stimulus on the contralateral side when both hands are touched. So if in a question they frame a case scenario that the patient is unable to identify the stimulus on the contralateral side when both hands are touched, so lesion of parietal lobe is suspected. Now other modalities relying on the parietal cortex. So what is 2-point discrimination? These are all rely on parietal cortex. So 2-point discrimination, the discrimination of two closely placed stimuli as a separate stimulus, stereognosis, identification of an object by touch and manipulation, and graphesthesia, identification of numbers or letters written on the skin surface. So remember the definitions of these important points or modalities from parietal cortex. Now gait abnormalities. If the decreased arm swing on one side is seen, corticospinal tract disease is suspected. Stooped posture and short-stepped gait, Parkinson's. Broad-based unstable gait, ataxia, scissoring, spasticity, high-stepped or slapping gait, posterior column or peripheral nerve disease. The patient may appear to stuck in a place. Apraxia with frontal lobe disease. So these are the few important gait abnormalities. So this was a short video from chapter 1 of the neurology section. Thank you for your patience, and you can like, share and subscribe this channel for more such videos in the coming days. Thank you very much.